I came into the field, we were talking about burnout in nursing and caregiver burnout. I don't even think we talked about it as nurse practitioners. We didn't even have that as an option. So burnout became a headline during COVID as we saw, and again, these aren't new issues. Providers that were losing life to suicide, substance use issues, impaired providers. So I think the fact that that's a little bit more spoken about is a positive.
Welcome to UpMed, a journal of healthcare's race to the bottom, hosted by Dr. Erika Urquhart. Join Dr. Erika and her guests as they pull back the curtain and share a behind-the-scenes look at the healthcare industry, all while providing solutions for better patient care and management. Now, here's your host, Dr. Erika.
Hello, and welcome to our podcast, UpMed, the Journal of Healthcare's Race to the Bottom. I'm your host, Dr. Erika Rowe Urquhart, and today we have a very special guest. She is a professor at the School of Nursing at Montclair State University, Dr. Courtney Reinisch.
Thank you, Erika.
Dr. Reinisch has a very distinguished background, and it's fascinating to really hear about her story, and I hope she'll share some of the details with us later on in our conversation. She has a bachelor's degree in biology and psychology from Immaculata University. She also obtained a Bachelor of Science in Nursing, which was an accelerated program, and this was from the University of Delaware. She has a Master of Science in Nursing with a concentration as a family nurse practitioner from the University of Delaware. And later then she obtained her doctorate in the practice of nursing from Columbia University. So as I said, she's a very distinguished, highly educated individual who is going to share with us some of her perspectives on her experiences as a clinical nurse practitioner professor. She also, I forgot to mention, works part-time with the public health department here in New Jersey in the township of West Orange. So, Dr. Reinisch, thank you once again for joining us. I'd like to start out just by asking each of our guests, we're all relatively seasoned, we're mature in our careers. What do you feel is your gifting or your professional niche in the area of clinical nursing?
Thank you for the question. Yes, it's kind of some days when I talk about the number of years that have gone by already, it seems like I blinked my eyes and I was just in school trying to figure out what specialty, where am I going to end up? So in my clinical practice, I loved primary care, underserved communities. My family is from South America. And when I trained as a nurse practitioner, we were really prepared to fill in the gaps. That was the language at the time. Acute care nurse practitioners were just starting out. Our history began with Loretta Ford and public health nurses in the community delivering vaccines to children in Colorado. And she went on with Dr. Henry Silva to open the first formal graduate training for nurse practitioners. So I certainly came from that background that the purpose of this role was to fill the needs, the gaps in care, the underserved communities, to focus on chronic care, where my gifts came and my personal interests. I love a little rush. So urgent care, as a graduate student, as an undergraduate nurse, I was in camps. I love sports and sports injuries. So urgent care became a fit for me in practice. And then we can talk about COVID and how I ended up in where I am today.
Let's do that. Let's talk about COVID and how you ended up where you are today. When you say COVID, I think it's fascinating because we're only 4 years removed from being in the middle of COVID. And yet, when you say the word COVID, if it's a word acronym, it means something different to every individual, right? We say it as if we are all speaking about the same
Mm-hmm.
thing, but in reality, we all have different experiences that shape what that word actually means to us. So, what does COVID mean to you? And how did the interruption of COVID impact what you do?
So I almost use the term COVID as a historical period. Yeah, when I say COVID, it's not just the illness, the interruption. So at that time, I was working for the School of Nursing. I was the inaugural undergraduate program director, which program startup kind of, I would say, is my current day niche. We were a brand new school in 2016. It was myself and my dean who started. So in 2020, we were still a very young program. I was actually doing primary urgent care visits for the student health service at the university. And the shutdown resulted in, first, it was an extended week of spring break. It was, what are we going to do with the students if all the hospitals and clinical rotations don't allow us? And where do we go from here? So, from my perspective at the time, I was working with primarily registered nurses that were associate degree prepared. So, they were going back for their bachelor's, they were completing their bachelor's degrees. So, I was already teaching in sort of an online remote version with those students because we're talking about working adults. So, I had scheduled Zoom meetings with them as part of my course. They were doing online modules. But in that beginning period, part of my Zoom meetings was literally just time to give them space to connect with one another, talking about it was harrowing in the beginning. Whether it was the stress of the lack of personal protective equipment, it was, friends, family getting sick. We knew nothing. They would talk about patients coming in, and 12 hours later, they were expired. They were deceased. The evolving, that whole first semester and into the fall, the science changed every day, where we began proning patients. We were intubating. We weren't intubating. We were putting people on BiPAP. So I was kind of a buffer for my students who were the frontline nurses, and thank you, all of them, for their service. Many got sick. Many were fearful of getting their families sick. So being my background, so the student health service shut down and began doing some contact tracing because there were still students on campus that didn't necessarily have homes to go to. So that although everything went remote from an education standpoint, there were still the students on campus. And then that's where I became involved with the West Orange Health Department. I registered as a Medical Reserve Corps member in New Jersey. And my initial assignment was public health with the West Orange Health Department. And that began with case investigations and contact tracing. And it evolved because in the fall of 2020, we were still remote with students. And I had said to the health director at the time, I was like, I have RN to BSNs who have clinical requirements for their integration capstone experience, for their
Yes.
public health experience. I said, we can get them certified on the New Jersey system was called ComCare, the electronic record. I said, we can build a workforce. And I said, and when there's a vaccine, we can build a vaccine program. And he said to me, and this was in the summer of 2020, he's like, oh, that's if this will still be going on. And I said, oh, this will still be going on.
Hello. Well, that's so fascinating, that you mentioned so many things.
Sorry.
Number one, no, I think it's just we forget, right? We forget the issues of supply chain and the immediate jeopardy that healthcare providers felt when COVID-19 hit. And I'm sure you were doing grief counseling as well as creating a sounding board for the nurses that were working and still pursuing their degree part time. I mean, kudos to them for hanging in there in the midst of all of that. And then that pivot toward preparation, being ready to administer the vaccine. Quite often, obviously I come with the bias of having an MD behind my name. There's always that dichotomy. Doctor nurse dichotomy. I come from that bias, but from a patient perspective and from a practical perspective, nurses are the ones that get the job done. And so I wonder if we can talk a bit about, again, this post COVID transition, but also being in the educational sector. What are the impacts of technology on getting the job done?
So, technology was a huge part and a challenge for a lot of people in education. I had always been on the graduate and postgraduate work. So when I was faculty at other institutions, I was involved in the preparation of nurse practitioners. This university, this was actually my first role with undergraduates with RN to BSN. If anything, when my boss first called me, I was like, oh yeah, call me when you're ready for graduate school. When you want to set up that graduate program, I'm here for you. I can write it, I can run it. So, but the using of the technology, the learning management systems, the Zoom, for me wasn't as big of a challenge. I know for many other departments, it was a huge challenge. There were faculty who didn't have their courses. And I would say that continues to be the challenge post-COVID and moving to everything electronic. I still read books in paper. I can do, I can read on a screen, but I don't find it as effective. And it's funny because one of my areas that I work in now is I am involved in publishing or being teams on textbooks. And we have all sorts of electronic resources. And they're like, we'll give you the copy electronically. I'm like, can I still get a paper copy, please?
Right, right. Well, I think that's so fascinating too, that you're on that cusp where you're creating a legacy for your field in terms of getting it documented and reviewing the textbooks. I think that's so important and something that we have to continue to assess. Spoiler alert, I feel after sort of hosting one season of this podcast that it has to become a book that, we have to talk about the history of healthcare a bit. So I'll be looking to you. But I think it's so fascinating because as you talked about the management systems, quote unquote, I wonder, every nurse has to deal with an audit of the assets that are utilized for a specific patient. So, when patients are taken care of inpatient specifically, but even outpatient, for the billing purposes of a facility, every ace bandage coming from an ortho standpoint, every dressing, every, medication, everything has to be audited, documented, attributed to a patient's account. So how is the training then for nurses to be able to play that critical role in asset management?
That's a great question. And it brings a smile to my face because I kind of laugh a little. So again, we'll go back to the Stone Ages of how I learned and how I began. And I can tell you, we would take, stickers, and we'd be putting the stickers if I was in the ER, because as a nurse, I worked in the ER, all the stickers in a code, we'd be putting them on or we'd be documenting, of course, time charting. We'd save the vials if we were administering medications quickly to then charge them out. Fast forward, electronic health records. Part of our systems in our university, we have a huge simulation center, multi-million dollars invested. And part of that is actually scanning, because we use scanners now for everything on an inpatient setting. So the patient's ID bracelet is scanned, and then we scan the medication that's about to be administered or the item that is to be used. Somewhere mid-career for me, we went to Pyxis systems and
Yes.
Omnicells, and you type
Yes.
in your number and you look up the patient's name and what the item was, and then the Omnicell door would open and you take out the item, or the medication, the drawer would pop open in the Pyxis. So it has evolved, and what we do on the education center side then is to literally, I have a ward in my second floor. I have ICU rooms. I have labor and delivery. And part of that is great because you can't guarantee every student. And we don't want every student to see a postpartum hemorrhage. Ideally, we want no one to experience those, but we can provide that experience in simulation. We have a home care lab. So like I said, I do community and public health. And during COVID, back to that vaccine program that we started, we were doing homebound. The county did a great job. And my RN to BSN and myself, my colleagues, we all volunteered for the county sites. And I'd go in at the first week, that Christmas week of 2020, they'd give us like, here's one vial. And when you use up those 10, we'll give you another vial. And then a few weeks later, here's 100 doses. We'll see you at lunch. And literally in 3 hours. So it was and again, that had to do with the guidelines changing, because in the beginning, we couldn't move it. We couldn't transport it. Yeah, that held up our starting a homebound program. But yes, we started a homebound program and we had to document. And I actually, even that is a skill that I teach students. So do you remember downtime procedures when you were in the hospital?
Oh, yes.
Yes, the carbon copy sheets.
Yes, absolutely.
And again, back in the Stone Ages, when I took verbal telephone orders, or I gave verbal telephone orders as a nurse practitioner, students learn everything electronically now. And we have an electronic health record that the students can use to document in our simulation centers to prepare them for using those systems in the hospital. But we start this vaccine program, and we had Wi-Fi, we had iPad, but I said, I've made a spreadsheet. We're going to document by hand. And they're all looking at me. I said, and here's a form. We're going to take all the demographic information, paper and pen, make sure we have it right. And the funny thing was, I didn't realize what forward thinking that was, because we're in the field. The Wi-Fi handsets didn't always work. The electronic, we'd still have to re-enter it and upload. And then the state came to audit the health department, and they're like, where are the paper charts? And we're like, well, we have our records, but they were always intended for us as just backup. It's all put into the state system, but the state still wanted to see the
They
paper.
still wanted paper. That's fascinating. And it's forward thinking that you had it, that you were able to sort of manage that. And that brings up, a point, because you have to ask beg the question, why is the state asking for paper? Who uses paper anymore? I'm in private practice. And, I was just having a conversation with someone this morning trying to do a gross estimation in a private practice. At the time, it was just my husband and myself, but our practice has been in existence for going on 25 years. We went electronic in 2007. We probably spent over $300,000 on, everything that is required to be electronic. So the servers, and I was talking about,
Sure.
the sundowning of the windows and everything, how, even if the system is working, it's got to be replaced because Microsoft will no longer service it, or it's no longer considered HIPAA compliant. And so, there's a huge financial investment in being electronic.
Mhm.
So I have to ask myself, why in the world is the state asking for paper?
The state is the state. What we do in private sector versus state sector is very different. And I agree with you. The funny thing was, even when the state came to audit or investigate what we were doing, and this was routine. This wasn't every pod vaccine provider had to go through this if you were getting state vaccine. So it wasn't that we were doing anything wrong, but I thought it was very interesting that they never told us we had to have paper charts either.
Right?
So,
You're
like I
dealing with
said,
it from both sides.
yeah, so we did this simply because I didn't, and again, I think that comes from the time when I was educated. Electronic health records were just brand new. And like you said, they were, what was out there then versus what's now is different and maybe slower, didn't capture everything. So that was, for me, it was my own sort of, I'm just going to dot my I's and cross my T's twice because I don't trust the Wi-Fi and the electronic system. And I have people, we're going out in the field. And remember, going back to COVID again, as a healthcare provider, everything changed every day.
Yes.
So,
Yes.
we were documenting our temperature logs and we were keeping them by hand because I didn't know if the data loggers, if the materials would always work. And they didn't always work. They sometimes failed. I mean, that's the reality of dealing with electronics. So I don't know why the state asked. I don't know why the state didn't tell providers up front too, unless they just expected everyone would have that. But a local health department is different than a community based or a private practice or a hospital system. So to even ask that, and we're not talking 20 years ago, we're talking today.
That's right. That's right. We're talking modern
Yeah.
times. We're not talking about the Stone Ages when you and I started out.
Yes.
So that brings us to the question of the day. Like for someone who does remember the good old days, how things used to be. Not that they were that great, but as someone who remembers that, what do you think about where we are right now? And especially as you are training the young minds who are entering this field with every aspiration of, wanting to be the best of what healthcare has to offer. How do you feel ushering them in to the system that we have now? What are your perspectives on the landscape for being a nurse now, 5 years from now, 10 years from now?
And it's interesting, I think, and it's not that it didn't exist before. I came into the field, we were talking about burnout in nursing and caregiver burnout. I don't even think we talked about it as nurse practitioners. Like, we didn't even have that as an option. So burnout became a headline during COVID, as we saw. And again, these aren't new issues. Providers that were losing life to suicide, substance use issues, impaired providers. So I think the fact that that's a little bit more spoken about is a positive. There is a model, and it came from the military, from the Navy. It's called stress first aid. And it talks about, and there's the 7 C's, given them, they came from the Navy, but there is a program, and I actually got trained to teach this with the nursing students, talking about a stress thermometer. So just the thermometer is green, yellow, orange, red. Green, we're ready to go. We're acting and behaving ethically. We're comfortable. We're confident in our skills. Yellow, maybe we spilled a cup of coffee. We had a fight with our spouse. Our dog ran away. yeah, we're getting to work a little stressed. Like, what do we need to do to get ourselves ready? Orange, now we're feeling the effects of stress, and maybe before we're going in for a shift. I mean, I know electronic health records came along, and we didn't have single sign in. I don't know if you remember this or
Mm-hmm.
not.
Mm-hmm.
I would be worried about all my passwords. How do I get the lab
That's right.
results? How do I get the
That's
x-rays?
right.
How do I document in my chart? Because they were all different systems.
Yes.
Is IT
Yes.
going to be able to help me? So that's the orange. And then red is when we see people really injured. This is when we're seeing symptoms of depression, anxiety, post-traumatic stress disorder. Obviously, our goal is to not have providers get to the red, to identify,
Right.
within ourselves, within our teams, when our colleagues maybe need a little more support, and really promoting that concept. And that's what the 7C's about: checking in with yourself, checking in with each other, supporting someone. Maybe you need to cover someone because they just had, you want to bring an ER to a halt, or a PEDS ER, bring in a PEDS code. The whole place is quiet after. And we all have to get back. And people are waiting.
Their patients waiting. Yeah. And so, it's so fascinating because I think you are the bridge between the theoretical and the practical. And what I have observed, practically speaking, is that for the reasons that many of us continue to work, the financial reasons, the family obligations, maybe the ego, any number of reasons, you have many people operating in orange or near red, but that's normal.
Correct.
That's
Correct.
expected because, you see people cutting corners in the OR specifically. That's where I think we see it the most because every minute is $1, right? But you'll have the nurses will say blocking cases getting done because in trauma centers because they want to create a break for themselves. So turnover time, instead of being whatever it takes to get the next room set up, 30 minutes, 45 minutes tops, and 45 is actually a long time. Turnover time is 60 minutes, 90 minutes. And that's normal because, again, of the stress, the work stress. You find individuals creating space for themselves, you know, sort of decompressing, right? It's a valve, it's a release valve. And so, where I think on the academic spectrum is a recognition of sort of this type of behavior a part of like the educational process, like where does this fit, because that behavior is normal.
Well, and that's it, building culture. And I said the only way, because part of this model that I was talking about that they were teaching is that this needs to be a culture within our teams. And I said, well, it's not going to be a culture because the culture is right now, as you're saying, suck it up, sweetheart. We got to go.
That's
And
right.
and when you talk about, part of it is staffing challenges. Everyone is short staffed, and that's demoralizing for a team. And then, and this is going back 10, 15 years, but I remember being a provider and just begging for, can we get one more tech in the ER to, because maybe we could decompress ourselves if we had a couple more people taking patients to the floor. Like, we have them, they're admitted, the bed is ready, the report is given. I have 20 more people waiting in the waiting room. I could bring them in if I could open up a bed.
That's right. No, we didn't have techs. The techs at Hopkins were the medical student. It's like, okay, we were working on medicine with, Osler, whatever, the Osler ward, Osler. They would say, look, we've done it all. We've written it up, or you wrote it up. Patient needs to get to the floor. Don't expect anybody to get the patient.
Right,
Go get
right.
the patient.
And we did it as nurses.
and and we were running like, no, they said no, don't walk.
Right?
Now, the patients might get a little frightened. Don't walk because you gotta handle that gurney on your own, and you better have some pep in your step. Get that patient out of the ER. And so, now it's residents, medical students, still orthopedics. If they need to get to the OR, we're not expecting a tech to take a patient to the OR from the ER. The resident is, it's like, I'm looking at you. You're the resident. Where's the patient? Get
No,
the patient. Get
I
the patient.
understand. And
But that's not right. That's not right. I'm not saying it's right. I'm just saying those are the measures, and that's the environment. When you see that on TV shows going back to ER and then Grey's Anatomy and everything else, you see that that's not fake. They didn't make that up.
and honestly, back when I was a nurse and when I was a tech, yes, I ran patients. But then when I became the nurse practitioner and I'm in the fast track, I can't do that. No, I can't
You can't
leave.
leave.
And, unfortunately, for all of these techs, nurses, there's no incentive, there's no RVUs. You know, we are buried in the payment as part of the bed or the room charge. And then
Yes,
you want to
that's
talk
right.
about demoralizing, you'd hear that, oh, the CEO of the system is getting a $4 million bonus and I can't get a tech for $15 an hour. And I would be told by the manager, oh, they're dime a dozen. I'm like, okay, then get me a dozen if they're a dime. That would be lovely.
Exactly.
Like that's not
Exactly.
the answer.
Exactly. Yes. How many how many nurse CEOs do you see? There are some, but it merits an article being written. It merits an article being written. Someone who actually knows what it's like to care for patients and what this conversation. I can't believe I just had this conversation this morning. The conversation was around the fact that there was no empathy, no understanding, and in fact, the caregivers were considered adversaries in the dynamic between facility management, hospital management, upper management,
Yes.
CEO, C-suite, and the actual physician, nurse cadre of staff that are actually caring for patients in the healthcare
Mhm.
environment. So, that brings us again to another problem. As we look at the Journal of Healthcare's race to the bottom, we found something. We found a couple of things. One, we found that asset management is something that begins in the educational track of nurses, which is fascinating, and that there are simulations. But the other is that the time and the resources that are required to maintain the accuracy and the level of efficiency that are required for those assets to be put into good use, that is something that there's a gap there. There's a need. That is something that could use some serious revamping and reanalysis to really say, okay, let's reassess. We're not quite there yet in terms of capitalizing on all of the benefits that technology could provide. And then the culture, from empathy for the type of work that individuals do, to providing adequate resources and support, to having a work culture where the dynamic of the different degrees that are behind individuals' names mean that we come together to work for the benefit of the patient, not that we come together to create our own silos and defend our own territories. That is something that also could benefit from an assessment or analysis. Courtney, what do you think? You get the final word.
It's funny you bring up the silos. And I've been championing at our university our interprofessional educational experiences to, I think maybe I remember going into healthcare and kind of not understanding when people didn't understand the concept of teams. And I grew up playing sports. So I was like, is that why I get it? But I love being a part of a team. So to me, and when I would even hear as a nurse, what are the nursing specific indicators? And I'm like, it all blends together. I don't
Yes.
know how I mean, I know you can, some things you can quantify. Was the medication given on time, the right medication? Was it documented correctly? We're all interdependent on each other. And until we can accept that, we continue to struggle as women, as minorities. I mean, our system has a long way to go, is what I keep finding, and I keep learning, and I keep working to try and break some of those down and address them for the next generation, because I recognize our time it's fast. It goes quick in our professions. I can't believe it.
Yes.
But, technically, you and I are going to be retiring in the next 10 years?
Yes, God willing.
Right? Yes.
But what you say is, again, what is the legacy? And what have we preserved or stewarded for the next generation? What healthcare institutions did we receive on our inauguration into this career and profession? And what will be left when we exit? And those are the big questions. And at the end of the day, I hate to say it, but my MBA taught me that at the end of the day, it all comes down to money.
Absolutely.
At the end of the day, we talk about culture, we talk about equity, we talk about technology, we talk about efficiency, we talk about doing the right thing for our patients, but we will never be able to do that until we manage the dollars that we've been given. So that's going to be another episode of this podcast. But I want to thank Dr. Courtney Reinisch. You are just a wealth of information. You have fantastic energy and such a positive spirit. We're so blessed to have had you on today. And we thank you so much for your time. We wish you all the best with your students at Montclair State University and with the Department of Public Health in West Orange, New Jersey. Thank you, Dr. Courtney Reinisch, for joining us.
Thank you for having me. It's a pleasure and an honor. And, I hope there's a nugget there that someone can walk away with.
Yes,
of a different perspective.
Absolutely. I think there are multiple nuggets. So thank you so much to our audience for joining us for another episode of UpMed, the Journal of Healthcare's Race to the Bottom. I'm your host, Dr. Erika Rowe Urquhart, and we will see you next time. Bye-bye.
Thank you for listening to this episode of UpMed. For more information on Dr. Erika, visit her website at upmed.us and her LinkedIn profile at Erika Rowe Urquhart. To continue the conversation, visit and subscribe to our YouTube channel at E. Rowe Urquhart. And don't forget to hit the follow button on your favorite listening platform so you never miss an episode. We look forward to joining you next time on UpMed, a Journal of Healthcare's Race to the Bottom.